active because I know this topic comes up a lot. And if you guys have any questions, please unmute yourself or send us text messages. So let's start off. So the lecture outline today, we're going to kind of cover UTI. Want to specifically cover differently in women and in men. We want to cover pyelonephritis and asymptomatic bacteriuria and bacterial prostatitis. So urinary tract infection is the most common indication for antimicrobial use in the hospital, and significant portion of the use inappropriate or unnecessary. You know, some of the data that shows in long-term care facilities and nursing homes, over 75% of our senior citizens get antibiotics yearly, and out of that, 50% or more is inappropriate. And one of the main reasons for treating our elderly patients with antibiotic is UTI. So I think there's a lot of room for improvement in this area. So some of the terms I'm going to use: cystitis basically means bladder infection, lower UTI, urinary tract infection; pyelonephritis, kidney infection, upper urinary tract infection. So UTI symptoms occur in about 20% of the women each year, 8.6 million office visits annually, and out of this, 84% are female. Half of all women have at least one UTI by the age of 32, and annual costs for UTI treatment is over $1 billion. I think it's way more than that, but some estimates say about like $1 billion or so. And me and Dr. Horn, we get a lot of UTI questions, outpatient setting, in the hospital. And a lot of times we're actually trying to stop antibiotics.
Right. Yes, the goal of stewardship is to use antibiotics appropriately. It's not always to stop, but UTI, there's a lot of room for improvement. And we'll talk a little bit about asymptomatic bacteria as well.
So UTI in Women Classification of Dysuria, pain on urination. With bladder, bacterial cystitis, which happens in the bladder only, usually it's about like 60 to 70% of the cases. Bacterial cystitis with subclinical pyelonephritis, so there might be a small component of kidney being involved. It's about 5 to 15%. And then there's a lot of times pain on urination is confused as UTI, but it's actually really due to sexually transmitted infections like gonorrhea, chlamydia, herpes. So I think that's important to keep in mind when we are thinking and treating patients with UTI. Other things can cause pain with urination. Vaginitis can cause pain with urination as well, which is external, the vaginal infection, not internal infection. So if you get Candida infection, Trichomonas infection can cause pain with urination too. That's about 5 to 15%. So it's important to know, is it true UTI or is it external infection? And interstitial cystitis with other poorly understood causes. So there are some other reasons, about 0 to 5% of the time that can cause pain. But the majority of the time, pain with urination, 60 to 70% of the time, is due to bladder infection. And most of the time when females come in, their biggest symptoms when they have UTI is urgency, frequency, and dysuria, pain with urination. These are really good symptoms that can give us a clue they have urinary tract infections. There are some other symptoms like nocturia, urinating at night, incontinence, lower back pain occasionally. Fevers usually implies upper tract disease. Not always patients have these symptoms with urinary tract infection. The main three symptoms are urgency, frequency, and pain with urination. Note probability of cystitis in greater than 50% in a woman if they have present with the symptoms. Greater than 90% if you have dysuria, and frequency without vaginal discharge or irritation. So pain with urination and frequency is a really good indicator of urinary tract infection.
Yes, and this is good. Usually if we get a call, the first thing we hear is what the patient's growing. Mm-hmm. And usually our first question is, what are their symptoms?
Yes.
Because if they're not having any symptoms, then we think of asymptomatic bacteria and look for other causes. But so that's usually my first question.
Mine too.
Is what are their symptoms? Yeah.
And that is so important. I really like what you just said, because a lot of times, the female external genital area, it's contaminated with lots of bacteria. So most of the time, even if you have E. coli or Proteus, these gram-negative organisms grow on the urine, they don't have any symptoms. That goes into the pile of asymptomatic bacteriuria, not urinary tract infection. So I think it's always really good to ask, do you have any symptoms in these patients, such as urgency, frequency, or dysuria?
And sometimes when we get it can be confusing when the patient first comes in to find out what exactly is going on with them. But usually if I hear the patient has a pneumonia plus a UTI, or they have a cellulitis plus a UTI, then I kind of wonder what are their symptoms, because a lot of people will grow something, and sometimes if the patient comes in, there's a lot of confusion, what's going on, so a urinary culture is done. But if they have something else like a cellulitis or pneumonia, my first thought is to treat that, and then maybe what's growing from their urine may not be clinically significant.
Yeah, and this happens to us a lot when elderly patients, they get transferred. They already have dementia, they already have altered mental status, and they might have aspiration pneumonia, but somebody got a urine culture and now stuff is growing. I will usually treat the other source, not so much the urine, because most of the time it's contamination or asymptomatic bacteriuria.
Yeah.
Cystitis versus vaginitis. So sometimes we can get confused external infection with internal bladder infection. So vaginitis pain is external rather than internal. You could have odor, fishy odor, especially with trichomonas. You could also have discharge with itching if you have albicans fungal infection. Usually there's no white cells on urine analysis. And pain with intercourse and lack of urgency and frequency. So that's more external infection, not internal infection. So there are sometimes we have to consider complicated UTI. So cystitis, usually pretty straightforward, but there are sometimes cystitis UTI can become complicated. So pregnancy is one of those times. It's considered complicated. If you acquire urinary tract infection at a hospital setting, nosocomial is complicated. Recent catheterization or instrumentation. If you have stones in your kidney or bladder, diabetes, recent antibiotic course, structural or functional abnormality of your bladder or your urethra. And also if you have recent renal transplant, kidney transplant, or if you're immunosuppressed patient. So some of these categories, the patient goes into a complicated category, which requires further imaging or longer duration of treatment. We'll get to that in a little bit. But some of these categories we should kind of think about, they might need a little bit more further workup.
And with patients with renal stones, that the stones can be porous, and so they can have bacteria in the stone that essentially is clinging onto the stone that you'll never get rid of. So if you keep doing urine cultures, it may always grow something, but whether or not they're symptomatic or how to treat that, really the best thing would be to get rid of the stones if possible. But those can be really difficult situations if patients have indwelling stents and stones. So
some of the physical exams, that is kind of suprapubic tenderness, it's kind of insensitive, 10% of the cases, but very specific. Also, a lot of times in our clinic, in our emergency departments, urgent care, we do urine dipstick. So if you get either leukoesterase or nitrates, it's about 75% sensitive and 82% specific. Leukoesterase is detecting for white cells in the urine. Nitrates are detecting for nitrites, element that producing gram-negative organisms. So that might sometimes help. So if the patient has symptoms and if they have some of the lab data like UA dipstick, then it kind of reinforces your inclination to treat for UTI. Microscopic, I like this a little bit more better because if somebody presents with urinary tract infection And what we call pyuria is like white cells on the urine greater than 5 to 10. That shows they're actually looking at microscopically how many white cells are in the urine, which is even a better test than a urine dipstick. And sometimes you could also have blood in the urine as well. And the most common bacteria in women that we find in uncomplicated cases are E. coli, 79% of the time. Staph Streptolyticus, about 11% of the time. We call it honeymoon cystitis. A lot of patients get it postcoital. Or other organisms are like Klebsiella, Proteus. So a lot of gram negatives and a few gram positive, like enterococci, can sometimes cause UTI in uncomplicated cases. But when you look at the complicated cases, E. coli gram negatives are still on the top. But then you start having more gram-positive bacteria like Staph aureus, Staph epididymis, Staphylococcus, enterococci. So that kind of falls into a more of a complicated UTI.
Yeah, and with Staph aureus, that's kind of a special one.
Yeah.
So if someone has Staph aureus growing in their urine, the general thought is it probably went, they could have been bacteremic, and then it went from the blood to the urine. So sometimes we'll get consulted, and sometimes some of the teams will say, we think that they had urosepsis due to Staph aureus, and they'll think that it went from the urine or from the bladder to the kidneys to the blood. And in general, the thought is it was probably in the blood and then went to the bladder.
So what we usually do is if we find Staph aureus in the urine and the patient didn't have any recent urological manipulation or Foley catheter or any other instrumentation, we assume that it got through first in the blood, then to the bladder.
Yes, especially if they had fever or chills.
Yeah. We actually end up getting blood cultures and treat the patient with IV antibiotics for longer duration of time.
Yes, if the patient had fever and chills, I mean, if you find Staph aureus there, you strongly consider doing blood cultures.
Blood cultures, yeah. We have had cases where we found Staph aureus in the urine, and then the patient ended up having epidural abscess,
or endocarditis,
and you just find other things, and the initial clue where we found it was in the urine, so it's something to keep a high alert for. So I kind of want to touch base on a couple of the antibiotics we have for UTIs. So nitrofurantoin, great drug, and I know you guys have also heard the price is going up for this, which is very unfortunate.
So the price just recently went up 400%, because their CEO said that he has a moral obligation to make money.
Yes.
Yeah.
So as ID doctors, we are completely very upset about that.
Yeah.
Spectrum of nitrofurantoin activity, it works really well for E. coli. It's kind of poor for gram positives, but it's really good for gram negatives. It does have some activity against enterococci and staph species, including VRE, but it's important to kind of look at the susceptibility, but gram negative, it's really good. Best taken by oral, good absorption with food. The thing to remember about nitrofurantoin is it's only distributed in the bladder. So we could use it for UTI, but we will never use it for kidney infection or any other type of infection, usually only for bladder infection. And I tend to not use it for patients with GFR less than 60. And some other stuff to remember is we get asked this on our board question all the time. Sometimes our elderly patients get put on nitrofurantoin for a long time suppression, but it can actually cause pulmonary fibrosis. So something to keep in mind.
Right. So, and that's one of the reasons, well, other than it not working, is that we don't like, as much as we can, we don't want to use antibiotics to prevent a urinary tract infection. And so there are patients that get put on nitrofurantoin indefinitely to prevent a UTI, and then the pulmonary symptoms are really the ones that are well known, right? That they'll get a restrictive lung disease, and it's really unfortunate, especially, you know, if at all it can be prevented, not putting them on something long term, that's what we do. Yeah.
And then other thing that we also see is a lot of our elderly patients in nursing homes, they got put on this for a prolonged period of time. But what ends up happening is the bacteria, for example, the E. coli they had, it slowly mutates and becomes more and more resistant. So we avoid prolonged antimicrobial use.
Right. Yeah. Prolonged antibiotics is really one of the things that they say, causes resistance.
Yeah. And I really like fosfomycin. This is an old drug, came out in 1969. It's coming back into practice again because its spectrum of activity is great. It is kind of expensive, but usually insurance cover it. The nice thing about fosfomycin is it's orally taken. You mix it in like a glass of water and you drink it. One dose, and it also lasts in the bladder for a long period of time. So for simple cystitis, you could do 1 dose and it should be good. For complicated cystitis, you do 3 doses every other day. But the nice area where we could use fosfomycin if you have UTI, just bladder infection, is for ESBL producing organisms. A lot of times we get called on like, patient has ESBL E. coli, do we have to give ertapenem? There's no other options. Do we need to put an IV line? And this is when we usually say, can we, we could use fosfomycin.
Yeah, and really it should only be used for cystitis.
Yes.
And so not for pyelo, that's exactly right.
Yeah, not pyelo, just bladder infection cystitis.
Right, but it's a good alternative to carbapenems, especially if the patient is outpatient and you want them to be treated.
And here's a nice chart for uncomplicated cystitis. So we could use nitrofurantoin, we could use Bactrim, we could use fosfomycin, fluoroquinolones, or beta-lactams, oral beta-lactams. So there are some options. The thing to remember is Bactrim and fluoroquinolones, there's more than 30% resistance to them. So just keep in mind some of your patients, if they're having an infection and you give them Bactrim or fluoroquinolone, if they don't get better, I think the importance of getting that culture and looking at the susceptibility is important because it might be a resistant strain and that's why they're not getting better.
Right, and if you have an antibiogram for your local bacteria, that would be the best, but a lot of places don't have that. But if they're being treated with something as an outpatient and you don't feel like it's working when they get admitted to the hospital, then change to something else. Yeah, it's usually not so much, especially for something that has good bioavailability.
Yeah.
It's usually not so much the change from PO to IV, but more of the choice of the drug that's being used. Yeah.
So usually what we do is if there's a patient that has bad enough UTI or urosepsis and gets admitted to the hospital, we never use fluoroquinolone or Bactrim as our first-line agent. We usually use like ceftriaxone, a beta-lactam, which has higher sensitivity and susceptibility, until we get the culture. And then once we know what the susceptibilities are, then if it's susceptible to levo or cipro, then I feel comfortable going to that.
Right.
But I don't use that. If I don't know the susceptibility, that's not my first agent in an inpatient setting.
Right. So if you're giving something with a good bioavailability, like fluoroquinolone or Bactrim, if it's not working, it's probably not the fact that you're giving it PO.
Yeah.
Right.
Cystitis, so if it's a simple cystitis, you see a patient in the office, outpatient setting, in the hospital, if it's simple, so 3-day regimen is perfect, plenty. And it's cost effective and works really well, and we don't create resistance. So 3 days is enough for simple cystitis in a female. So diagnostic studies. When do we do imaging if you have cystitis? So imaging is it's very low yield for most women, unless history suggests some abnormal urinary tract. But there are some indications for certain patients where you should get imaging, especially if children are having UTI. You should consider getting an ultrasound, because they could have abnormal urethral structure, reflux. If you're suspecting stone, if you're suspecting a young male with recurrent UTI, you're treating the patient with the right antibiotic, and despite that, they're not getting better. Then you have to think about, is there an abscess or something like that? Recent urological surgery, repeated pyelonephritis, if they're immunosuppressed or if they have sepsis of urological origin, these are times that you should think about getting, okay, I might need an ultrasound or a CT scan. But if it's simple cystitis in most females, you don't need imaging.
Right, and the renal ultrasound, I mean, in simple cystitis,
Yeah.
I wouldn't really think about doing an ultrasound so much, or a CT. If you did a CT, it might see thickening of the bladder wall. It might see some air in the bladder, which if they haven't had a Foley catheter or any instrumentation might indicate they might have an infection. But in general, for a simple cystitis,
recurrent UTI in women. So most of the time it's reinfection, but something interesting to keep in mind is if you have a female with E. coli infection, she keeps on getting over and over again the E. coli infection, that E. coli is going to slowly become more and more resistant. And we see this a lot in our patients. You could pull up their electronic medical record, and then you pull up the susceptibility pattern, and over a year, if they had multiple UTI, the E. coli has now become so much more resistant. So this happens a lot. Management option, every time they have UTI, you treat the patient. Sometimes you can give low dose prophylaxis, nightly dose Bactrum or nitrofurantoin. And sometimes postcoital, you could take some antibiotic. Not a lot of good studies with this though. And then there's some unproven, but it may not be harmful, is like wiping front to back, and voiding after intercourse may be helpful.
And when you call it a recurrent UTI, so if the patient comes in and you test them, you get a bacteria, you get the susceptibilities and treat it appropriately, then sometimes we'll have a question, should I retest them to make sure that it's gone?
And I usually don't retest them.
No, so especially if their symptoms go away and they're symptom free and they have the appropriate treatment, then you wouldn't need to retest them. Yeah,
because that's when we get into now the colonization and bacteriuria. So no retesting unless, let's say, a month later she has the same symptoms again, then we could get another urine culture at that time.
Right, because it's essentially, sometimes they'll have that bacteria go away and another bacteria come in and colonize. And so having good flora, good colonization is okay.
Yeah.
So sometimes patients will be treated and then they'll no longer have symptoms, but they'll be tested to make sure it goes away. And then they'll say, oh my gosh, it's back, or something new is there.
Yeah.
And then they'll treat that, and then they'll test again, and they'll,
so no cultures, no testing if they
unless
don't
they have symptoms. Right,
yes.
right.
Perfect. So
pyelonephritis, so signs and symptoms. So localized flank pain, this is CVA tenderness. So here's want to include a picture. So if you push right here where their kidneys are and they have pain, so that would be the CVA tenderness. CVA, so that's costovertebral angle tenderness. Low back pain, so they might have low back pain, but not so much when you palpate there, when you push there, but they might just say, I have low back pain. Abdominal pain is possible, fever, rigors, sweats. They could have a headache because it could be that they're bacteremic with their pyelonephritis and they're having just generalized symptoms. But I wanted to show a picture here of where to push on their back, and if they do say they have pain there, or they have, they might have UTI symptoms in addition to CVA tenderness, then I would consider treating it as pyelo. So there's a wide variation in severity. So some patients will be extremely sick. They'll be in the ICU. They don't like saying urosepsis so much anymore. They say sepsis of urological origin, which, okay. And then, so mild pyelonephritis may mimic cystitis. So they, as that slide earlier showed, that they might have some an infection in the kidneys, but they may not be exactly symptomatic from it. Or it may just be starting the illness. They may be severely dehydrated. Rare complications are they can have a necrotizing pyelonephritis or an abscess or septic shock. So if they do have an abscess, you kind of take it as each patient individually. And if they do have an abscess, it may need to be drained. Would probably be the best thing for them.
Yeah, especially with pyelonephritis kidney infection. I think these are the times where imaging is okay with ultrasound, because we have caught a bunch of cases where young females with pyelonephritis and had a large kidney abscess, and it was loculated, walled off. The thing about kidney abscesses are, if you don't drain, it can get bigger and bigger, and you might actually lose your kidneys. So it's really important to have that higher degree of suspicion when you have pyelonephritis to see, do I need imaging?
And as far as abscesses go, we'll have questions of, well, how long should we treat this patient for an abscess? And abscesses there's a wide variability of how they could be a small abscess, a big abscess, it could be loculated or not loculated. So ideally it would be, you have them put in a needle and drain it, CT-guided drainage of the abscess. It will also get susceptibilities. If they're large and loculated, they may need to not only be drained, but have a surgeon go in and remove it. As far as duration of therapy, well, we want to make sure that we're treating it appropriately with the right antibiotics with a susceptibility report. But then I'll treat it and then re-image it at some point to make sure it's going away, because I don't want to just kind of have an arbitrary time for it, especially if I'm not sure if the antibiotics can get in, penetrate the abscess, and they're actually effective.
No, that's a really good point.
Do you have a duration that you treat? Or
Usually, for abscesses, it's a longer duration, 4 to 6 weeks. But during that time, I'm re-imaging to make sure that abscess is draining, because sometimes it stops draining and you still have a loculated area. So I think getting interventional radiology as surgeons and keep working as a team to make sure.
And being very aggressive with it and everything. So yeah, I like to treat and then re-image at some point, maybe in 2 to 4 weeks or so. It kind of depends on the case, and then make sure it's improving and going away, and then essentially giving antibiotics as long as needed until it's gone. That's usually the question we'll ask our residents and fellows: how long do you treat? Until it's gone. Uncomplicated pyelonephritis, treatment of mild infection. So if the patient's able to take PO, so if they're not vomiting, they're a compliant patient, you can give PO antibiotics. Usually you want to make choose something that has good bioavailability, like a fluoroquinolone or a Bactrum or something like that. Antibiotics, and here it says the same as cystitis. So that's except for nitrofurantoin and fosfomycin. So those, remember, only get into the bladder very well, and you wouldn't want to treat a kidney infection with nitrofurantoin or fosfomycin. That's simply because the concentration, it doesn't get high enough concentration in the bladder to be effective.
The kidneys.
Oh, sorry. Sorry. Yes, in the kid, it doesn't get high enough concentration in the kidneys. It concentrates in the bladder. Sorry. So asymptomatic pyelonephritis in women. So some women are actually asymptomatic. There are some risk factors like low socioeconomic status, past pyelonephritis, pregnancy, known UTI abnormality, so that's a tract abnormality, or symptoms of greater than 5 days, which is the most reliable predictor. So when do you hospitalize them? So if it's possible to treat them as an outpatient, so why would you hospitalize? Well, if they can't take the antibiotics, if they're vomiting, if they have any question of sepsis at all, so low blood pressure, if they're immunosuppressed, even with diabetes might be a reason, renal calculus, so if you're not sure if you can really get rid of it, or you might want to be more aggressive and call the urologist to get rid of the renal calculus. Pregnancy is high risk patients, concern for adherence to treatment regimen. And uncomplicated pyelonephritis and treatment of severe infection. So hospitalize, you want to do a urine cultures. So gram-positive, you can use ampicillin, vancomycin. Gram-negative, a third-generation cephalosporin, something like ceftriaxone would be a good plan. Aztreonam, so if a patient has a penicillin allergy and you want to use something other than a beta-lactam, aztreonam would be a good choice. Gentamicin, so if you have a patient that is you're concerned about sepsis or septic shock, gentamicin might be a good thing to use, but the problems with gentamicin come from more of a long-term use. If a patient has sepsis or septic shock, there are studies that show just if patients that get a 3-day course of gentamicin while you're doing cultures to figure out what it is and what it's susceptible to, didn't have any issues with hearing or kidney issues at all. So if a patient is extremely sick, that's when I would consider doing gentamicin. Is that?
Yeah, we usually do a cephalosporin with aminoglycoside combination, and kind of get the patient stabilized and wait for the cultures and susceptibility. So
right, and sometimes people will do a one-time dose of gentamicin when they first come in.
Yeah.
I don't know that there are great studies showing that, but the thought is that gentamicin will have a good post-antibiotic effect. So even after it's gone, it will continue to work, and the organism will most likely work on the organism.
And the nice thing about gentamicin is it concentrates really well in the kidneys and the bladder. So if you are going to do, you probably want to do the high dose gent dosing, not the synergy dosing 3 times a day. You would do one time, 5 to 7 milligram, one time, once a day dosing.
And usually I only do that for patients I'm worried about.
Yeah, me too.
And then Bactrim and quinolone. So these work, but if the patient has been getting these, or in most areas there's a lot of resistance. So
like we talked about before, I wouldn't use that as a first line unless you know the susceptibility. Then you can.
Uncomplicated pyelo, and this is treatment duration. So initial episode, if you give less than 2 weeks, it has a higher relapse rate. 6 weeks, no better than 2 weeks. So we recommend a 2-week treatment for pyelonephritis in general. So there are exceptions to the rule, but if someone says, how long should I treat this pyelonephritis? 2 weeks is usually what I say. UTI in women and duration of treatment. So this is your cystitis. 3 days works well. So 3 days, I usually don't go longer than 3 days.
No. Initial recurrent 3 days, but pyelo 14 days. There are some studies coming out that you could do shorter, like 10 to 14-day course. But right now, some of the standard is 14-day course.
And so for those patients where they say this patient has a pneumonia and a UTI, or they have a cellulitis and a UTI, sometimes by the time it grows out, it's already day 3. And then I'll say, well, you're treating the pneumonia. I would consider that was also treating the urinary tract infection if they had one. So if they had 3 days, I would say that's fine. Yeah. And then complicated UTI, there's no standard. 7 days is probably the minimum. And then if it's complicated, if there's anything not straightforward about it, consider a urological evaluation for stones, or for if they have it recurrent, or any concerns at all, really. Asymptomatic bacteriuria. So this is, so bacteriuria is just having bacteria in the urine. Patients with positive urine cultures who lack symptoms of a UTI have asymptomatic bacteriuria. So these are the patients that will get consulted on, and sometimes it's by outpatient providers, so they'll see the patient in the clinic. And the one I usually think of, I don't know if this is something you think about, but it'll be a 94-year-old woman coming in, and the patient will say she's tired. So she's a 94-year-old woman that feels tired, and then they say, oh, well, we'll look for a cause. They check the urine, something grows, and fatigue or being tired isn't one of the symptoms we usually think about. And they don't have any pain with urination. They don't have any frequency or abnormal smell or color or anything with their urine, but they'll get treated for it, and then sometimes they'll get rechecked a couple weeks later, or they'll come in and
it just becomes more resistant.
And then they'll come in 3 months and say, the provider will say, how are you feeling? And they'll say, I'm tired. And then they keep getting treated. So what we usually do with those questions, we'll call the patient and say, how are you feeling? And then they'll say they're tired. And we'll say, well, you've been getting treated for this, you've been getting treated for a UTI, 12 times in the past year, or every month. Do you feel like it's made a difference? And or do you feel like you need to be treated? And sometimes they'll say, no, it hasn't made a difference at all. And so we'll say, oh, well, perhaps, are you okay if we don't give you any antibiotics? And sometimes they'll say, no, that sounds fine with them. So that's the good outcome. Yeah.
One of the big reasons, it's really important not to overtreat our elderly patients is because of C. diff now.
Right.
We see so many patients that are treated for UTI that get C. diff. If you're over the age of 65 and you get C. diff, your mortality goes up 50% or more, your bad outcome. So I think all of us as antibiotic stewards do need to be really careful about is it asymptomatic bacteria?
Yes, and sometimes, and the difficulty here is because sometimes it's hard to tell.
Yeah.
And that's the part where ideally we would have better tests and better ways of checking. Then that's really where a lot of the confusion comes in or the tests aren't as good as they should be.
And I always feel like, don't follow the lab, follow how the patient feels, ask the patient.
Yes.
Sometimes like the patient is feeling completely fine. Again, if you grow something in the urine, ignore the urine if she's doing okay.
And for the 94-year-old lady, sometimes they'll develop so much resistance that's when they bring it to us and say, what should we treat with?
Yeah.
And we'll call the patient and then we'll say, oh, well, we recommend not treating. And sometimes it's hard to do it first, but when you do it and you watch the patient and you see that they're actually doing okay without treating, and this shows the prevalence of asymptomatic bacteriuria in selected populations. So different things can cause increased amount of bacteria in the urine, or increased likelihood that you'll find it. And if you look all the way to the right, it says 100% with long-term catheter use. So patients with long-term catheters, really they're going to grow something, and the difficulty is figuring out if it's if that patient needs antibiotics or not. And that can be, those are the difficult patients.
And also, if you guys look right there, intermittent catheter, which is straight capping, 89% of the time you're going to have something in your urine. So anytime we're putting instruments into our bladder, you're going to introduce organisms in there, and you're going to grow multiple organisms. So that's important to know on biofilm, and it's just going to grow. But if they have no symptoms, don't treat.
Right, and it's hard to have symptoms if they have a chronic Foley.
Yeah.
So we'll have questions where they say, well, this patient, their Foley catheter smells so bad that they'll treat that. And that's a difficult situation because we don't want to treat just for smell, especially if the patient is feeling okay. And sometimes these might be spinal cord injury patients that have a chronic Foley, or and with these patients, if we keep treating just for smell, then when they get really sick, then their antibiotics won't work. And so that's a difficult situation. I try not to treat unless they have a fever or leukocytosis.
That's exactly, I try to see other symptoms of infections.
And sometimes the patient will say, I just feel sick, I know I'm sick. And I trust those patients because they know what they know their body sometimes very well. And so if they say, I feel like something's coming on, I trust them. So this is asymptomatic bacteria incidence. This is important because it shows with age that the incidence of asymptomatic bacteria goes up. And so just with older age, you're more likely to grow something.
And I really like this slide. So not asymptomatic bacteria treatment is not indicated, but there are 3 times indications where you should think about treating. Pregnancy, if you have asymptomatic bacteria, is an indication for treatment, because if you don't, you have preterm labor or bad outcomes with a baby and mom. Renal transplant, if you get a kidney transplant within the first 6 months, if you had asymptomatic bacteria, treatment is appropriate. And if you're going to have a urological procedure like cystoscopy, stents, any type of urological procedure, if you find bacteria, it's okay to treat, because when you're going to go in there and manipulate and try to get the stone out or put a stent in there, you could have transient bacteremia. So currently, literature only supports asymptomatic bacteria treatment is for pregnancy, renal transplant in the first 6 months, and pre-op urological surgery.
Yes, I think this is an excellent slide also. And the pre-op urological surgery, the plan, and you can just give a one-time dose before the surgery. And really, it's not to sterilize the bladder, but it's to help keep it in the bladder and help keep it from going into the blood. So it's in the blood, the antibiotics are in the blood, and it's to keep the bacteria from going from the bladder to the blood and then continuing to grow in the blood and causing bacteremia. So you're not trying to get rid of it, you're not trying to sterilize it, you're just trying to keep it out of the blood. Sometimes we'll see patients get admitted to the hospital 3 days before a procedure to have IV antibiotics for 3 days before they have their surgery. That's actually I think the urology and the ID groups say that's not really needed. You can just do it before the procedure.
Just like, when we give pre-op antimicrobials for abdominal surgery, CT surgery, for urological procedure, you could give antimicrobials prior to the, ideally like an hour before or so you have good concentration.
Yep, exactly. And UTI in men. So incidence in young men is less than in young women. Increase in incidence with age. So this was similar to the previous slide, that men and women, as they get older, they might have a higher likelihood of growing something. Likely due to increased prostate, so the prostate can cause issues. Asymptomatic bacteria in 20 to 50% of men in nursing homes. So there's a high incidence of asymptomatic bacteria. It's just good to be aware of it. UTI symptoms in men. So dysuria, frequency, urgency. They can have obstructive symptoms like hesitancy, bacteriuria, slow stream, dribbling. Neither sensitive nor specific. Now, sometimes when men have a urinary tract infection, sometimes you'd want to treat for a longer duration, and that's kind of this question of, do they have an occult prostatitis that I'm not aware of, or I'm not treating correctly. So you might need to treat longer if you're considering prostatitis.
Prostate infection.
Yeah. I don't know of any really good way of diagnosing a prostate infection.
Yeah. I usually get like the urology doctors involved if I truly believe, and I think doing a prostate exam is important because you'll feel boggy prostate and things like that. I'm not an expert in prostate exam, so usually if I'm worried about prostate infection, I get the urologist to see the patient.
Yeah, I don't usually do the general exams. That's hard enough where they can feel the pain, but not hard enough you're going to make them bacterial. It's like, so
I think a urologist, an expert to do that exam will be really good. And sometimes urologists actually can take some fluid from the prostate for cultures as well. So that might be really helpful if you're worried about prostate infection.
So 75% gram-negative rods. So always want to consider E. coli. 20% gram-positive cocci. That's enterococci. Gram-negative, coag-negative staph, and saprophyticus is rare. And then as far as UTI treatment in men, 7 to 10 days. High-low, 2 weeks. If you're considering a occult prostatitis or you want to treat longer, that's okay. They'll recommend 4 to 6 weeks usually with something that gets into the prostate really well. So prostatitis, relatively uncommon. The same organisms, they can be systemically ill, and most antibiotics get into the prostate, like Bactrim or fluoroquinolones get in okay.
And so a lot of antibiotics have a hard time getting in, but like Dr. Horn was saying, Bactrim and fluoroquinolones have really good bioavailability into the prostate. So I think this is when it's really important to know the culture and sensitivity. Then you could just use oral antibiotics to treat the prostate infection. But yeah, usually for prostate infection, you're treating the patient for a long time, like 4 weeks or so, and urological evaluation and post follow-up.
Yeah, and for these patients, I like getting a CT scan to make sure they don't have an abscess. Exactly. Oh, and that looks like it's everything. Now, if anyone has any questions, you can feel free to unmute yourself, or we can also, if you'd like to type the questions, we can also see the chat box. So if there are any questions, please feel free to ask.
We kind of covered UTI, pyelo, prostate infection, and asymptomatic bacteria. A lot of times this comes over and over and over again in our hospitals, and I'm sure your hospitals too. Any questions at all you guys have?
Some of the questions that I get, they'll ask, do you find the procalcitonin to be helpful in cystitis or pyelonephritis? What are your thoughts on?
So, great question. So, like, cystitis is an infection, it's contained in the bladder, so you're not going to have procalcitonin that's elevated. If you have sepsis of urological origin, then it'll be elevated because you're having systemic inflammatory response. So I don't usually depend on procalcitonin unless you have a sepsis-like picture, inflammatory response. I'm not sure if it's good for UTI, but pyelonephritis maybe if they're having a sepsis-like picture.
Yeah, and that's my feeling. Yeah. If it's something straightforward, I wouldn't use it. But if someone's very sick in the ICU, you can check it. And if it's high, you want to make sure it's coming down. But it's not something I would base a lot on it. Yeah. But if it's high, I would definitely want to make sure it's improving. Yeah. But it's not something that we normally order for a urinary tract infection. Yeah.
Well, if there's no question, we will send out the recorded video, and then you guys could email us with any questions. Thank you for joining us. And next time we were thinking of presenting on latent and active TB. We got a request to present on that, so we're going to do that. And please send any more requests, any topics you guys want us to cover. Thank you.
Yes, thank you very much. Have a good day, everybody.
Thank you.